Hi there, this is Marielle Concepcion, your host of the My DPC Story podcast. Have you or someone you care about ever been burned by the U.S. healthcare system? If so, you are listening to the right video, because if you are listening, chances are the answer is yes. But the U.S. spends so much on healthcare. Why are so many Americans affected personally and especially financially by the healthcare system? Shouldn't that mean we have better healthcare access and treatment options? Shouldn't it be easy for us to be able to see our doctor when we need to instead of turning to the ER or urgent care? Historically, it's been seemingly impossible to answer these questions. But now that is changing through the direct primary care movement. This video that you have tuned into will bring you into the world of direct primary care and show you how physicians all over the country are changing the way they practice so patients from all backgrounds get the high quality care they need and deserve, which makes for both happy patients and physicians. Learn even more by subscribing to the My DPC Story YouTube channel. Find us on all major podcast platforms. Find us on socials at My DPC Story and at mydpcstory.com. There you can find resources including how to find a DPC doctor near you, conferences about DPC, DPC startup guides and advice, a store with DPC swag, and even a mapper showing where podcast guests are practicing. Thanks for tuning in to hear about this powerful movement. Now, on to the episode. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
For me, it means going back to the roots of primary care. For me, it means freedom.
For me, it's going back to take care of patients and practice medicine like we're supposed to do.
I am Dr. Rosa Torres.
I'm Dr. Oscar Torres.
And this is our DPC story.
Dr. Rosa Torres was born in León, Nicaragua, where she completed her medical education at the Universidad Nacional Autónoma de Nicaragua. She was doing an intensive care residency when war broke out, and she had to move to the United States with her husband, Dr. Oscar, and had one child, Dr. Kissy Blackwell, at the time they made their move. Dr. Oscar Torres Jr. was born in Managua, Nicaragua, and has been married to Dr. Rosa for over 40 years. He graduated from medical school from the Universidad Autónoma de Guadalajara in 1980. He practiced medicine in Nicaragua for 2 years before coming to the United States in 1982 because of communism and war. Together with his wife, barely speaking English, they moved to the U.S. and worked very hard to pass the required medical equivalencies before starting residency at the Wichita Falls Family Medicine Residency Program in Wichita Falls, Texas. Upon completion, Dr. Rosa worked as a faculty member in the same program. They graduated from the Wichita Falls Family Medicine Residency Program in 1991 and 1992. And then they opened their own practice, Texoma Family Clinic, in 1991 in Burkburnett, Texas, and spent 23 years in a private practice before joining United Regional Physicians Group. Then, in January of 2019, they decided to open Texoma Direct Primary Care in Burkburnett as well, making it the very first DPC clinic in Burkburnett. Welcome to the podcast, Dr. Rosa and Dr. Oscar.
Thank you for having us.
Thank you for having us.
Now, at the time of this recording, you guys have just survived Snowmageddon 2021. How was that for you guys as a family, but also for your practice?
Well, it was quite an adventure. We learned a lot to survive, and the patients learned how to survive also, because they know how to get a hold of us for sure.
I guess with the teledoc or telemed that we had available through the Atlas MD, you will be able to kind of access our patients at home, and we didn't have to, kind of miss any kind of issues with the patients somewhere and be able to take care of them whenever, the situation was difficult to be in the office. So it wasn't that bad. And also my nurse be able to work at home through that because she have access through the Atlas MD from the iPad and her phone. And we're able to kind of access the records on an iPhone here at home and send prescriptions or whatever we need to send message to our patients.
I'm glad that your patients were able to still get a hold of you under the conditions that Texas experienced.
Yeah, that's very important.
Now, I want to highlight that you guys are the parents of Dr. Kissy Blackwell in Wichita Falls. And I love that you three are all doing DPC.
Yes, we are Dr. Kissy Blackwell's parents, and we have another daughter in medical school, last year of medical school, that is also thinking about going into DPC when she finishes residency. So pretty soon we will be 4 Torreses.
That's amazing. Is your second daughter in Texas as well?
Yeah, she's in San Antonio.
So let me ask you this. When you guys talk as a family, with you having entered the DPC world in your own clinic, with Kissy having had her practice, what are some of the conversations that you guys have with your second daughter with regards to DPC and questions about DPC from a medical student's perspective?
Well, I think, DPC that require, a lot of your skills to be practiced at the office. Okay. So you kind of miss some of the private practice, after medical school, being in the hospital, being in the field, learning how to do a lot of different stuff. If you come directly from medical school to do DPC, you're going to have problems. Okay. Because, there's a lot of, procedures and stuff that you need to be doing as a DPC doctor, and it's expected as a DPC doctor to take care of your patients so they don't have to go and spend a lot of money going and be referred. So I think that it will be wise for the medical student, and when they go and before going to DPC, kind of have some few years of practice in order to develop the skill that they need to be able to survive as a DPC doctor.
And Dr. Rosa, do you have anything to add to that?
Well, this is one of the things that we are concerned about with our second daughter in medical school, because it's true. We went into DPC practice after more than 30 years of experience. And so a lot of what you do in DPC practice is basically based on experience and what you have learned through the years. So we wonder if she would be better going through a couple of years of fee-for-service or some other kind of, like a community health center or something for extra training. Even learning the system is not a bad idea before you go into DPC and decide if this is what you need to do. Our second daughter in medical school, her name is Caros. It's actually Oscar backwards.
Oscaros.
I love it. How did you guys pick Kissy's name?
Have you ever read a book named Roots?
Yeah.
So Kissy means stay put. Yeah. But we changed we didn't put the ZZ because in Spanish there is no ZZ sound. So we just named her Kissy, Kissi. That's where we got it from. Yeah.
Just going back to your answer there, it's a very interesting take on a recommendation to other aspiring DPC docs, because I definitely see where you're coming from. When I look back on my own, having worked in fee-for-service for now more than 5 years, I appreciate direct primary care differently than I would have had I not gone into fee-for-service first.
Yeah. And I think you're more secure of yourself in what you know and what you do. And we learn from others. So practicing with other physicians and learning from them is actually a very good experience. And it makes a difference between what it is, what do they call him now? A practitioner and a family practice doctor,
Absolutely. Now, you guys had your own private practice for 23 years prior to joining United Regional Physicians Group. Is that correct?
Yes, that's correct. And it was in the same town where we are, same building, actually.
Wow, that's pretty incredible.
We actually signed in our contract. That was one of the things that we signed, that we were not going to have a compete clause in our contract. If we decided to just,
But they don't do it over here for nobody.
Finish. Yeah.
They don't do it.
There is other clinics here that have the same compete clause, and they make them pay money, to kind of go and practice around certain kilometers of a distance. Otherwise, they have to move away to whatever the contract says.
That is really wonderful that you guys were able to negotiate that into your contract. And because of that, and because of you maintaining your presence in the same building, when you transitioned to DPC, did you have a lot of your patients who you've been taking care of for years come over to your DPC practice?
That's correct. Yes.
Yes, it made it easier to have patients come to our office, because we were able to actually contact the patients before we finished working with the hospital. So we created a small panel of patients when we were able to open our office. So we already had over 200 patients. Yeah. So those were our patients from before. But we did have a big panel before. We had thousands of patients that were not able to join us. And we did have a limit of patients we were going to take anyway. So that was the purpose, trying to slow down and have a smaller panel.
It goes back to smaller panels means more personalized care. It just, that's how DPC really brings value to patients.
Right. Exactly.
Are you full now?
No, we're not full. This town, Burkburnett, it's a small town. The hospital opened an urgency type of clinic at a few blocks away from us. And that helps people that have other needs. So we're not completely full, but we do not advertise. And so it's just what we get word of mouth. We think we have enough, but we're still taking patients.
Stay with us. We'll be right back. My DPC Story just hit 100,000 downloads on Apple Podcasts alone, and we could not have done it without our amazing listeners. So to thank you and to celebrate this milestone, we're giving away an incredible DPC Summit prize package for the DPC Summit happening in Minneapolis this summer. The prize includes My DPC Story swag, and on top of that, the prize also includes a ticket to the DPC Summit. Check out my interview with Dr. Jeff Davenport, where you'll hear more details about the summit. To be eligible for this giveaway, all you have to do is first rate and review My DPC Story on your podcast listening platform. Pro tip, if you rate My DPC Story with a 5-star review, it helps the visibility of the podcast and it helps others to find all these DPC stories. Number 2, take a screenshot of your review and email it to support@mydpcstory.com. You'll find that email in the show notes as well. And third, make sure you're following My DPC Story on all your social media platforms: Instagram, Facebook, TikTok, YouTube, LinkedIn, and Twitter. All the social links are at the bottom of mydpcstory.com and also in our show notes. For bonus points, share both this episode and the My DPC Story posts about the DPC Summit with your community. The winner will be announced in a future episode, so make sure you tune in to find out if you'll be heading to the summit. If you've already purchased your ticket and you're the winner, My DPC Story will send you a check for the price of your ticket. Thank you for listening to My DPC Story, and best of luck. When you say that you think you have enough, can you describe for the listeners, what does that mean in terms of the way that your workflow is going during the day, how many emails you answer per day? What does having enough look like for you guys?
A usual day for me would be 3 to 5 patients a day, but usually spend the day at the office. People that sometimes want to have a video consult, or their refills to be made, or like you say, emails. draw blood early in the morning, which we have a nurse that works for us. So we are actually Dr. Oscar, our nurse Mary, and myself. And they, among the three of us, we take care of all the patients all day. But, the day, it goes at a much slower pace. The patients can spend as much or as little time as they want. And the main thing, their time is respected. If they have an appointment at 4 o'clock, their appointment is going to be right at 4 o'clock. We are very careful with patients' time.
That's wonderful. And with you guys offering telemedicine as well, do you offer visits after hours if somebody like a parent is unable to make a weekday appointment?
Yes, we do. I have, a couple of times I've had gone on a Saturday to the clinic, opened it up and see a patient that needed to be seen because of wheezing or whatever. And it's not very often, but it does happen. Yes. Suturing, like sometimes somebody cuts themselves, and usually that doesn't happen on business hours, right? They can happen in the afternoon or on a weekend. So we do that. Yes.
I'm laughing here because, injuries don't tend to happen between 8 to 5, Monday through Friday. When you guys were in your private practice and then you signed on with
United Regional, yeah.
Yeah. When you guys were in your private practice and transitioned from your private practice to signing on with the hospital, United Regional Physicians, what led to that transition specifically?
Well, the main reason is when Obamacare happened, a lot of the private offices began to join hospitals because there were a lot of requirements and a lot of, what's the word for that?
Paperwork.
You have to Medicare, because we were Medicare participants, we were supposed to meet a certain quotas and certain requirements. And it was becoming more and more difficult to manage the practice with just our own resources. And so we decided that it was better if we joined the hospital. By that time, they were already pushing for doctors not to practice, admitting their own patients to the hospital. And so that also hit our revenue. There was a lot of difficulty in that category. Then Kissy joined the hospital when she came from Fort Worth. And, for two doctors, economically, it made sense at the time. And that was the main reason why we joined them.
That was, Yolanda was the Medicare kind of requirements to kind of keep, be able to do the billing and be able to kind of participate, to be Medicare participant or Medicaid. They go and require that you have to do all these kind of parameters or whatever, that you have to send it to them and be compliant with that. It's a lot of kind of paperwork, kind of consume a lot of your money there, and they don't send you money for that. Part of that was also the electronic medical record that we had to implement it too. Okay, that we didn't have electronic medical records then. So, but the government said, we need to do electronic medical record, but we want to send you money for you. It's your problem. So all the kind of stuff, kind of put you in a big kind of financial kind of stress. And then
meaningful use came with that too. So it was not just to have electronic medical records, but you also have to comply with meaningful use of the electronic medical records. So you needed to demonstrate to the government whatever you were saying with your electronic medical records. And I mean, it really takes a lot of manpower and a lot of money to keep a private practice running like that. So that's why we joined the hospital.
And at the same time, we used to see our own patients. I meet a patient for pneumonia, I meet a patient for gallbladder disease or whatever, and see the patients in the hospital, make rounds, and then go to your practice and do your private practice there too. And so the hospital say, we don't want the family doctors to come to the hospital anymore. And basically everybody had to from the hospital. So they're going to die with hospitalists and stuff. So there was a lot of kind of movement, kind of completely changed the whole way to practice. So it made it kind of difficult. So Kissy came over and made this thing easy for us. Said she didn't want to work with us. And she said, I'm going to join the hospital. I don't want to deal with this stuff. I just want to have a paycheck. And that was it. So it make it simple for that. I said, well, I guess probably we can do that too. And we just kind of switch over. And then at the same time, when we, after 4 years, we start practicing with the hospital and same staff, okay? The hospital, because they were pushed by the government, also you had to meet some quota, you had to do some parameters that were measuring you against our peers and all that kind of stuff. And so they give you, say, 8 as a goal, and then you make the goal, so next time will be 9, and next time will be 10, and keep pushing and keep pushing. They're never satisfied, whatever you do, you always, never can get the goal. So all that kind of stuff. And beside that, the hospital didn't like the resident program that we have here in town. And that kind of threw the last drop out of the glass when they said that they're going to shut down the resident program. We were very supportive of them. We were teaching to them too as well. So when they do that, we said, that's enough with the hospital. We don't want to do with this stuff. And then, so we decided to go to DPC.
And I didn't know that prior to talking with you guys, but, it's just, I'm shaking my head here because it's just so disappointing that this is where our healthcare system has gone. As a resident who experienced full scope rural family medicine, specifically for myself, I created my own track for rural family medicine. And I went back out to Nebraska during residency where the physicians are only family practice doctors. And so the fact that you guys were supporting a residency to train the future doctors in family medicine with all of the experience that you had brought to the table, especially still practicing hospital medicine, it's just devastating to hear that.
Yeah, it was sad. We have gone through at least 3 changes in our practice because of, governmental things and hospital changes. But one of the saddest thing was having to leave the practice of admitting our own patients. And then the next saddest thing was having to quit teaching residents after they closed the residency program. I was actually interim program director for about 2 years and was part of the faculty at the beginning of my life in medicine here. And so that was very sad for me. And one of the reasons why I was ready to leave the hospital, I didn't want to have anything to do with them at the end. Yeah.
We are so happy to tell you, we don't want to deal with you anymore. Get out of my office now, because they were renting our office then, okay? And they were paying us for the office, and we were getting a paycheck for the hospital too in our own office. But we didn't sell the building to them. So when we done, we were kind of happy when they kind of shut out the resident to say that we don't want to deal with you. We just want to go ahead and quit working with you and get out of our office now, because we want to take it back. So I didn't give that satisfaction, okay?
I hear you. At least there was a little satisfaction there with all of the dissatisfaction that you guys were experiencing. I think that's so important that you guys shared that, because if there are physicians out there who have been in their own private practice clinic or have been part of a hospital system, it goes back to what you're saying in terms of your recommendation for those who are entering medicine in general after residency, experience the fee-for-service model. And I think again on how pretty much everybody I meet in the DPC space has their story of what pushed their buttons so far that they were done. And for you guys, hearing about how the hospital system continued to change, and then once they dropped the residency, that was it for you guys. It goes back to that idea that you can't really, yes, you can learn from others what the experience is like in fee-for-service, but if you have experienced corporate medicine in fee-for-service and being told by somebody, you're not seeing enough patients, or your diabetes A1C numbers are not controlled, and, you think as a doctor, how is somebody who's not a clinician, who did not go to medical school, telling me what I need to do?
Yeah. And there one other interesting thing that was happening with the hospital, they were comparing us with nurse practitioners. They were actually comparing the same parameters And they were putting us on the same list with their nurse practitioners that were under the supervision of one of their doctors and compare us with them. And of course, they were always better, because they were always being helped and corrected by their primary care that they were working with. And so that was another thing that pushed our buttons, that they were comparing pears and oranges in a situation that was completely different. So we made them do a different list, compare nurse practitioners with nurse practitioners and compare doctors with doctors. You can't put us on the same list. And that's how they would actually keep us under their boot, that it's a way to tell you that you're not as important. They can substitute you very, very quickly. Yeah.
And just given the years that you guys worked to earn your medical degrees and to earn your place in the medical community in Burkburnett, it's insulting.
It was.
In the beginning, when you talked about what DPC meant to you, Dr. Rosa, when you talk about freedom, what did that look like at the beginning of your practice in DPC, and what does that look like now?
Well, let me tell you, at first we were going to join Dr. Blackwell. And we were going to try to make a single office, like we were going to be there, a satellite practice of her practice here, because she was already full. But even that was part of what we did not want at the time, And so we decided that we were going to go on our own. And so she has her DPC practice here in Wichita Falls, and we continue with our practice in Burkburnett. So that's what freedom meant for us, because it would have been a lot easier if Kissy just helped us manage the management part of the clinic. But we had been in private practice ahead of her, and even though she had a lot to teach us, we somehow knew, my husband especially, Dr. Oscar has always been the managing partner, knew how to manage an office. So for us, freedom was freedom from everything and from everybody. So we basically came along. And so right now, it means that I have my own schedule. It means that, I don't work on Wednesdays. It means that I see my patients for as long as I want to see them. Nobody can tell me how many minutes I can spend with them. The best practices continue in our office. We actually are very careful with that. But like I said, with the experience that we have, it makes a difference to feel secure and safe of what you're doing. So that's what it means for me. Maybe Dr. Oscar wants to say something else.
Yeah, I guess it's going back to long time, the way that doctors used to practice, okay? You took care of the patient, you practice medicine, nobody tell you how you're going to run, how to practice medicine. And the patient, you deal with the patient directly. You send the bill, you give the patient to the bill right there, and the patient pay you right there. So back to the basic, back what it used to be, back what the country doctor used to do, and go and see patients at home, and get paid right there, and it's been respected, and you do whatever you feel is the best for your patient. Okay, now we have a lot of people in between the patient and us that tell us what to do. That tell the patient how much they can spend on the staff, how much they're going to cover the medications and services. And I tell the doctor, you cannot charge that much. We're going to pay you whatever we want. And you can keep yourself quiet. Okay, and don't start screaming or whatever. So the doctors are very independent, okay? So we're supposed to have their own mind. All the doctors, we are like that. And the administrators want to put the pressure on you to tell you who's the boss. And we don't like bosses. The doctors have independent mind. We all are. So we don't like bosses at all. And that's what the government tried to do. Put somebody that don't know nothing about medicine because of money have the power over you. DPC give you the opportunity to go back to what you're supposed to do, practice medicine, take care of your patients, and you do the best you can to take care of them.
Absolutely. Now, when you guys were transitioning into your DPC clinic, what challenges did you guys overcome having thought in the space of your private practice clinic with billing insurances to an insurance-free practice?
The most difficult part of this was to actually train the patients and teach the patients and make them understand how the system works. They still have a hard time understanding how they pay a monthly fee, even if they don't come, There are some patients that have come join us, and then after 6 months get an insurance, and they call and say, you know what, we just got insurance, so we're going to leave. And you know what? They turn around and come right back because they had no idea. They had not really understood the concept, of primary care. So that's really the most difficult thing, like I said, has been making the patients understand the concept of DPC. And then for me, the most difficult part is always the managing part. So I'm sure Oscar can tell you a lot about that. And him and Kissy have actually found a system to work together. We call her when we have a problem, and she teaches how to do it. She's really good at managing her office, and she's really good at teaching him how to do it. So our nurse and Oscar know what they're doing with the money. I have no idea.
I think that, yes, I get it that Kissy also your daughter, but in general, the DPC community is so supportive when it comes to, I'm not sure how to do this. Can somebody help me out? And even just putting, a general SOS out there on public forums, you'll get so many different ways to think about doing medicine. So I think it goes to, Dr. Oscar, your comment about, we don't like bosses. I think that is felt in the bones of every person who is a believer in DPC.
And a physician, we are physicians are like that. We're supposed to be independent thinking, okay? And we're supposed to kind of solve problems for the patients, okay? And instead to kind of have you to solve problems, people make the life difficult, okay? The medicine is difficult for you to take care of patients, okay? The administrators want to kind of tell you who's the boss because they pay the bill. And they're going to say, no, you cannot do this, you cannot do that, you can try this over here or whatever. So they don't know anything, okay? Why are they going to go ahead and just tell us what to do?
Yeah, I'm going to give you a quick example of what that means. We've always been used to take care of our emergencies. We do have a little emergency room, that we built for that. And the hospital, one of the first things that they did was they took away our emergency equipment, our crash cart, we called it. And we had actually gone for a week to give them room to move in, and kind of set it up the way they wanted it. And when we came back and we figured out we didn't have an ambu bag, we didn't have any medications to give patients that would show up as an emergency. It takes 20 minutes for an ambulance to make it from Wichita Falls to Burkburnett. And we could not make them understand that was not the way you practice in Burke. You have to take care of patients right there. And, their only explanation was that because we didn't do it often enough, it was not safe that we took care of our patients there. Does that give you an idea of what we were dealing with?
It makes me feel physically so uncomfortable to hear that, because as a person who physically lives 45 minutes from the nearest hospital, it's so wrong, right?
Right.
I have no other words other than wrong, because who suffers at the end of the day is the patients.
Right. Exactly. So anyway, that's why we were so happy to be able to say goodbye to them. And now we keep in our office whatever equipment we need to take care of the patients. And I cannot tell you how many times we have actually even got the hospital out of trouble because we did it anyways. If the patient showed up there like they always did, we did it. And they couldn't say anything about it. If you save a life, right there, right then, whether they like it or not, that's the way small town life is. But now we can do it our way. And that was one of the things that we do differently again, like we used to back in the old days.
With the residency not being there anymore, do you guys have medical students and residents come out to your DPC practice and see what you guys do?
We don't have anybody right now. And part of this, of course, COVID came in the picture. We have had requests from medical students, and the problem is that with COVID, you have to provide PPD for them too, PPE, I'm sorry, equipment. And it became difficult to have them. But as soon as we're able to, if a medical student wants to come and see what we do, or a resident, we will be more than happy to accommodate them. That's what we used to do. We had a resident every month. They would come to do their family medicine rotation, rural rotation with us. So we are willing, and we probably will as soon as we can.
What has your PPE situation been, just for yourself and Mary, your guys' nurse?
Actually, we have received equipment from the TMA, Texas Medical Association, and we have been able to purchase our own. So we're doing okay. Because we don't see that many patients, during the day, we don't really have a lot of trouble with that. But we do obtain samples. We do it at the parking lot. So we do utilize the whole, gowns and mask and face covers, etc. It's becoming less and less, thanks God, but we've been doing it. So.
And will you guys plan on carrying the vaccine for your patients in the future?
Well, we have every other vaccine, but we don't have the COVID vaccine because it wasn't available through our supplier. So I don't know. They really, I guess, they wanted in kind of large amounts. They want to vaccinate tons of people instead to have a few hundreds. So, but if we had available through our supplier, we would be able to give. We'll be happy to do it. So it's a matter that
just like we do with the flu shot, Eventually, I think if this becomes a yearly injection, I guess we're gonna do that ourselves too.
And I would hope that you guys could leverage the fact that you guys are, geographically within 30 minutes of Kissie's clinic, that you guys could argue that, your total population is greater than just the individual clinics' populations.
Yes. It's really not 30 minutes away. It's about 15 minutes away, but yeah.
It's only 10 miles at 75 miles per hour from here, okay?
Yeah, but the population is different too. We only have 15,000 people in Burke.
Less than that,
14,000, yeah. Yeah. So our population, it's a lot less. We do have a base, the Shepherd Air Force Base. We do get some patients from there. And you had a question about the Chickasaw Indians. We do have some patients from that population. Not many, but I end up sending prescriptions to the Chickasaw Medication Distribution Center. That's how come I know more about that. It was kind of funny that you asked about, because I just recently been dealing with them about a patient. So, yeah.
Dr. Rosa, with you seeing patients from the Chickasaw Nation, do you see any challenges with a DPC taking care of patients from particular nations?
I don't see any. Because you cannot make a difference of where the patients come from. I don't change the system, and I don't charge them more or less or make any changes because of where the patients are coming from. I guess you could make a specific arrangements with specific populations or places of work or something like that, but I don't really see any problems at all. No.
It's really interesting to hear, because I've never personally worked in Indian health. And so I love that you're able to just seamlessly give care to someone from a particular nation, in your case, the Chickasaw Nation, like you are anybody else. It makes common sense to me, but that's good that, as you're dealing with the bureaucracy that exists in fee-for-service, that there's no added layers that you're experiencing from patients who are of a particular nation who, as we know, care to the indigenous population is very skewed compared to people who have other forms of insurance.
Right. But because we're not dealing with insurance, like I said, and like I was telling you before, the education of the patients is our biggest challenge on how to have them come over and join your practice and understand what you can do for them. So the most I deal with, or that we deal with in that sense, is they have to use their card to be able to get the medication. And so they may or may not have the medicine, and you have to get prior authorizations. I mean, we still are not able to get out of that box, but we do what we can, try to help the patients to get the best. And so they get their medications, some of them free, some of them don't, but it, it can be done. It's just a matter of educating the patients.
And I'll ask you guys a question that I asked Kissy as well. How do you guys work with the law that exists in Texas with regards to physicians and self-dispensing?
We are not allowed to self-dispense here. We can actually dispense samples, but we cannot sell and dispense medications for a price. I think there is a law, and to be honest with you, we haven't even explored that, but I think you could provide 3 days or something, like emergency weekend kind of medicine, but it's not something that we regularly do. We're still fighting for that. I think they are talking about it in the legislature, but I don't think we are allowed to dispense medications.
But we have some other services that probably, I don't know, you heard about them. It's like Good RX. Okay, that basically if the patient joined there for $100 something a year, they get very discounted prices in all the medication. Okay, and it's really good. It's called goodrx.com. There's an app also in the iPhone and also in the Android that patient have access. Whenever you prescribe something for them, they can look at it and immediately they can choose which pharmacy is the less expensive one in your community. So that seems to work very well for a lot of patients because it really makes a big difference in the payment for medication when they go to the pharmacy. And all the pharmacies accept it. Walmart doesn't accept GoodRx because they have a own program of $4 kind of deal. The other pharmacy sometimes is convenient to go and check the other pharmacy locally and pick whatever is less expensive. Sometimes the problem with that is patient get one medication in Walmart, the other medication in our pharmacy, and just kind of jumping around. So a lot of time we get confused on what we're going to send the prescription.
But we don't dispense, but we try to help the patients to find the cheapest alternatives, and cheapest pharmacies for them.
Absolutely. And just as a side note, Kissy, what she explained to me was that she'll do the 3-day, she'll minimize what she can do to self-dispense with the 3-day rule because of the law still having, not passed the legal hurdles in Texas for you guys to self-dispense. Geographically, is Burkburnett far from a mainstream pharmacy like CVS or Walgreens, or do you guys have one of those types of pharmacies in town?
15 minutes away.
We do have local pharmacies. We have 2. And then there is a Walmart that is probably about 50 minutes away. 15 minutes away, yeah. So it's really not that difficult, And the local pharmacies are pretty good on trying to help the patients too. So we don't really have a lot of difficulty there. We do dispense flu vaccines, but those are in a different category. We charge a minimum, whatever
our cost.
Our cost basically is what we charge the patients. But that, like I said, it's in a different category that they don't look at it as medications. We also dispense like IM medicines, things that are needed to give relief in the clinic, for a very nominal price, like if the patient needs something for a Toradol injection for a headache or something, they'll pay like $6 or something like that. Yeah.
Injection, like a knee injection, arthrocentesis and stuff like this, or maybe injection in the shoulder, steroids and stuff like this, and little procedures and stuff. Last time I did a circumcision in an adult that because he didn't have the money to go and see the urologist. So I did it for him and it didn't cost him any money. Okay, so just pay the membership fee.
That's pretty incredible.
What we're talking about, you need to have some experience because that patient, needs some help. He don't have the $400 to go and see the doctor for first time and then charge another $500 for the procedure. Okay, and he having phimosis big time. Okay, and the guy had problems, infection and everything else. So I just buy the bottle and do it in the office. And Mary was very, very, very worried about it. But he did okay, thanks God. Okay, so I mean, it is stuff like this that you need experience to be able to kind of provide the best care you can for your patients at the DPC.
Do you guys offer services to non-members?
No. We basically try to stay away from non-members. Yeah, that's the short answer to that. And you're talking about like somebody come in and doesn't have a contract with us and is sick, like a sick clinic. Is that what you're asking?
So more so if you guys had someone who needed like a procedure, for example, would you offer one-off services for like a mole removal or a knee injection?
Probably not, because, you want to build a relationship with the patient, be able to take care of that. I mean, this is like working in the ER, okay? So the ER doctors have just one chat with the patient. So you made a mistake, you made in big trouble. So you want to build a relationship in family practice in order to kind of feel safe that you're going to take care of the patient and the patient have a rapport with you. So I don't want to go ahead and be just kind of just looking for the money, we can say, doing that kind of just a one deal kind of procedure and then that's it.
Well, I think some direct primary care doctors are doing like cosmetic procedures and things like that for people that just walk in, but we're not. We only do work for our patients that are contracted with us.
Definitely. And I think that, you guys, for your patients, that's the value that you bring to them. Like if you are patient population, you get access to this type of service.
Without having to pay anything extra, right?
Absolutely. Now, I want to go back to the education part of your potential patients. What is your elevator speech when you're talking to either patients, family members who are not yet patients who are thinking about it, or just members of the general public who are learning about the practice but are not really sure if it's right for them?
Well, we talk more about the personalized service to the patients, being able to come and see us when they're needing it. They can reach us anytime they need us. They have the possibility of telemedicine if that's what they prefer. And for the patients that don't have insurance, it really becomes a big difference. And in that, they then understand what it means to have insurance and what it means to have a doctor, which are not exactly the same thing. Yeah, that would be our short version of a, like you said, elevator spiel.
Well, I tell the patients, you have access to me a phone call away. Right now, with your insurance, you have a wall between you and the doctor. There's a big wall that you have to jump on it in order to access the doctor. And when you're able to get to talk to the doctor about your issues and your problems, okay, you need to be seen right away. People are going to turn you down and send you to the emergency room or to some kind of rapid clinic care kind of office because he doesn't have time for you because his schedule is full. All right, so you're a phone call away from me. Okay, you call me, the nurse will answer the phone immediately, or I will answer the phone personally. And that's it. So you're never going to get this anywhere else. It doesn't matter if you have insurance or not, you don't have access to your doctor when you need through the insurance kind of deal.
Yeah,
so that's a different
put in a different way. Yeah.
Like you guys mentioned, how some of your patients will get insurance and then 6 months later, they'll find themselves right back on your doorstep because they realize that oh yeah, I actually could just call my doctor.
Yeah. And they said, I have a toothache and I need some antibiotics. I haven't pain or whatever. And the doctor can assist you. Go to the ER, go to the clinic care, go to the rapid clinic or whatever. Can I see you here? And then you spend $150 or whatever, for visit the doctor just for that visit. And then you can call me and Mary answer the phone, or I will answer the phone. Sometimes when Mary is sick, unfortunately, Mary gets sick with the COVID this time, and she was out of the office for 2 weeks. And guess what? Dr. Rosa and I answer the phone. She answers the phone. We take care of patients, send the prescription, see the patient in the office, do the vital sign, the whole nine jar. I mean, you just name it, okay? We do everything ourselves, okay? So, and the patient were kind of surprised that we see us doing the whole deal ourselves.
Well, picking up the trash and and cleaning also.
It's basically the access. It's basically the way that it's supposed to be back with the country doctor. You call him and he come and see you at your house, or come and see you. You come to the office, take care of you, and you pay the bill right there. Now we have somebody in between the doctor and the patient making the calls.
Yeah.
That unfortunately is our healthcare system in the insurance world. Do you guys offer home visits for your patients?
Yes, I used to have a patient that had to go to Granville. That is 10, 15 miles away from Burkburnett.
It's a town in Oklahoma, actually.
And my patient was very sick. He couldn't come to visit me, so I just went to see it to his house. Yes,
yeah, we do home visits quite
not
regular.
all the patients. We got the patient that can come in. We can do it in the video chat. That will be okay. But the patient need to be seen at home. I want to visit.
Yeah, me too. I have a couple of hospice patients that I do home visits also. So, yeah.
And Dr. Rosa, how do you manage hospice patients in terms of if a patient wishes to use a hospice company, like there are hospital-run hospices and private hospices, do you manage everything from admission to when they pass, or do you work in conjunction with other hospices and have those hospice companies bill Medicare for hospice services? How does it work for you?
Actually, I allow for the doctor from hospice to manage the patient. And I think Dr. Oscar does the same thing too. But I was actually working for a hospice until not so long ago as an extra on the side job. They needed somebody and I helped them. So I became, for some of my patients, I was the hospice patient and they were my patients too. So which, that was a little complicated, but it can be worked up, it's no problem at all. But for the most part, the patient's doctor, the hospice doctor, is the one that will give, because I don't want any confusion in regards to especially pain medications and stuff like that. And if the patient is hospice, there are some things that will be covered by their Medicare. And if I get involved because I have opted out of Medicare, I can complicate things out. So it's better to just leave the hospice physician take care of that.
And when you were doing the side job with hospice, was that prior to opting out of Medicare, or while you?
It was actually now as a DPC doctor, but there was another doctor. The problem is that she was pregnant and she was needing help. So everything, they were paying me kind of like a fee, like whatever they pay, an hour. And I think all the paperwork was going under her name. The Medicare charges for the hospice was actually signed by the other doctor in order to do their charges and stuff.
You stated that they offered you the job.
Yeah, they did offer me the job, but I'm not gonna join Medicare just to join hospice,
They wanted to join Medicare so you can go ahead and keep working with
opt in again with Medicare. So no, I don't. Thank you, but no, thank you.
I'm glad you mentioned that, because I know that recently there's been some chatter about how to manage hospice as a DPC doctor on some of the public forums. So thank you so much for sharing about that.
Yeah, and that's the problem. If the patient has Medicare, you actually have to you would have to opt in with Medicare again to be able to, honor those services. And so I don't think it's a very good combination. I mean, you can do it, but it would be different.
With you guys, and I know we touched on the residency, but have other doctors reached out to you who are in private practice or who are in hospital fee-for-service clinics to ask about joining DPC? And if so, what fears have you heard from those doctors?
Well, I just had one that reached out to me last week. She's a hospitalist and she wants to leave the hospitalist environment and become DPC. And so we're in the process of, I already talked to Kissy about her. And so I'm going to give her this book. It's called Direct Primary Care Practice that she can read. I think I advised her to get educated on it first. This is one of my residents that I had when I was at the residency program. And so she is thinking seriously about doing the transition. So, probably will refer her to the Direct Primary Care Alliance to try to get more resources there and see what happens. But we do. We have to go to the meeting too. Yeah, she probably has to go to one of the meetings too. But we have had people that ask about the practice and how we do it. I mean, it's a process, it's not something that you get to do it right away. So we have to educate ourselves first and then go into it. Mainly the education, they don't really understand exactly how is it that we sustain ourselves if somebody is just paying us $50 a month. And so when you sit down with them and really explain how it is, and how the numbers actually end up every month, depending on how many patients you have, at first, they have a hard time understanding how it's done. I mean, a lot of these doctors are like this doctor that is working as a hospitalist. She's making good money there, but she wants to go back and be in her boss. She wants to get from underneath the boot. So she needs to educate herself and figure it out first.
In addition to the book that you mentioned and the DPC Alliance, do you have any other resources that you recommend to others using?
KissyBlackwell.com.
She's an expert at this time, okay? She's been very educated and she's an entrepreneur, okay? So she
very good entrepreneur doctor, yeah.
And she will help too because she loves it so much that she will help people because she was helped a lot also when she started. And so she's paying back that. So she was willing to help anybody, okay? And she's very active, I guess, in the
Alliance, yeah.
In the Alliance and also in the DPC kind of Facebook, whatever deal is over the group and the Facebook.
Oh, yeah.
Yeah, she was kind of looking at this stuff and she's answered everybody's question too. So
that's an awesome answer, and only one that ever could so lovingly come from her parents. I absolutely love this. But yeah, Kissy is definitely so selfless when it comes to helping others succeed in DPC.
You have seen that in Facebook. She always kind of answers everybody's question there.
She does. No, we didn't touch on your transition from Nicaragua.
Well, of course, there is a lot of time between the time we came to the United States and when we were accepted at the Wichita Falls Family Practice Residency. There are 7 years there that, where we worked at hospitals in Houston while we were passing our exams. And, I drew blood. I was a phlebotomist. And Dr. Oscar was a telemetry technician first, and then he was a surgical assistant and a heart cath lab assistant. Technician, I guess you can say.
Yeah. So when the initials of the heart cath and also the PTCA, then the beginnings of that back in 1983, 84, something like that, I was involved in that as a technician working with the nurses and the doctors, the cardiologists. So it was a lot of learning, but even though you pass the test, it doesn't matter. I mean, nobody give you opportunity to go into the residence. So we basically stayed, even passed the test, maybe 5 years before we can get into the resident program. And that was one of those lucky times that when we, I recall that we had the, what is that, the
matching,
book, the matching book that they give it after the matching was done. So all the places available that were no match. So I start, checking, the book from the beginning. And at the end of the book, by 4 o'clock, was Wichita Falls. So I said, well, let's try Wichita Falls, the last one in the book over there. So we'll see what we come up with. And at that time, we heard Wichita Falls. We kind of remember there was one, our friend's doctor that was making the one residency there. So we made sure about that. And then when I called, I just mentioned then his name. And I said, so you want to know anything about me, just kind of consult with him. And that was it. And 15 minutes later, they give us a call back and said, yes, we consult with this guy, with Dr. Molina. And he can say, yes, that guy is okay. Go ahead and give it a chance for an interview. And I said, the medical director is coming to Houston. We were in Houston then. And I said, I want to see you in the medical center. I have a meeting there. But by the time it was maybe 11 o'clock or something like that, and bring your papers with you. That was it. So, it's a long story. I made it make it short, but
that's how we ended up in Wichita Falls. And then a year later, I went into the same residency program.
I actually think it's really important though, because it wasn't, an easy, oh yeah, I just went into residency after we, fled from Nicaragua to the States, that you guys did work and what you were doing, because so the way I think about it is, okay, so say there's someone out there who is applying for medical school and they are serving right now as a phlebotomist, or they are serving right now as a tele-tech, and they hear your story. I mean, they might reach out to you to be like, how did you gain the confidence to change from doing telemetry technician or working with a cardiologist's office or doing phlebotomy to becoming a doctor? So I think it's really important to include those little details. I don't think they're monotonous. I mean, it's like, heck, like I used to teach zoo camp, and I use the lessons that I learned from teaching kids every day when I see kids in the office, right? So yeah, I think that's important. So I love it, and yeah. It really fleshes out, your medical journey. When you guys think about everything you've been through, your transition from living in Nicaragua to coming to the States and practicing medicine in fee-for-service, and then now in DPC, what are some techniques that you guys use to thrive as individuals, as a couple, and as DPC doctors?
Well, it's persistent, okay? We all doctors are persistent, okay? You want to be a doctor, it doesn't matter how far away it is, how difficult it will be, you're going to be fighting until you get what you want. So that's what you need. So it doesn't matter how difficult it make it for you to kind of go through, become a doctor. We were physicians back in Nicaragua. We had difficult with the war. We had to leave. We had to learn the language here. We had to keep passing the test in English. We passed it 2-3 years after that. We couldn't get interviews because, they don't know us. Okay, so you don't have no help inside the system here in the United States. It's very difficult for you to get an interview. So finally, until, it kind of break through, because a friend of mine, Dr. Molina, kind of give it the okay, I had the interview. Okay, so it's persistent. Okay, so you want to be a doctor, it's a long wait. You don't get scared about it. You keep pushing yourself. And that's what you need. You basically just kind of be persistent what you want. So doctor, we all are like that, okay? Otherwise you cannot be a physician because it's a long career. 4 years over here, 5 years over there, 10, 15 years, and keep pushing yourself. You have to keep learning all the time. So it's difficult. It's time to be a priest. The physician is the second one. And I have a friend that he was a physician and then became a priest. How about that?
Well, I think consistency, persistence, and you have to have faith on yourself, and just keep on going. As a couple, we always supported each other. When one is weak, the other one is strong, and so you can limp on one side, but the other one will help you get out of the hole. So we've been married for 43 years now, and we have worked together all of those years in the same office. So people still ask us how do we do it. I don't know how we do it. I guess
close to each other.
A lot of love for the profession and a lot of love for each other.
That's so wonderful. So I want to ask you guys now, if others wish to reach out to you after this podcast, what's the best way to get a hold of you both?
Well, you have our phone numbers.
They need to identify us as doctor, whoever, when they're going to talk to us, because, with all this kind of, spam and all the kind of robocalls and stuff, if we don't know where this comes from, we don't answer the phone.
Yeah, so if it comes through the office, actually, and
they get doctor, whoever want to talk to you,
we'll call them back. It's no problem at all. Yeah, they can reach us through the home at the office.
Perfect. And I'll make sure to include your contact information on the accompanying blog with your podcast.
Yes, that will be fine. We'll be more than happy to help anybody that needs help.
Yeah. And then we refer to Kiss it Blackwell.
It's been such an honor to speak with you both today. Thank you so much, Dr. Rosa and Dr. Oscar, for joining us today on the podcast.
We enjoy talking to you, Dr. Concepcion. You are very nice, and I wish you the best with your program, and be persistent and consistent. You'll get where you want to get.
And if I'm needing any help, I'll ask Dr. Kissy Blackwell.
Yeah.
Next week, look forward to hearing from Dr. Whitney Pack, formerly of Cortez Pediatrics in Cortez, Colorado. A huge thank you goes out to the listeners who subscribed to the newsletter this week. For those of you not subscribed, there's still time before the first exclusive announcement happens. Let's just say it features a previous guest. To find out more, subscribe to the newsletter today. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends too. For more information on this episode and much more, please visit mydpcstory.com. Also, for the latest in DPC news, check out dpcnews.com. Until next week, this is Marielle Concepcion.